We are live.
So good evening, everybody. On behalf of AIOS and the IOC, this is the 5th International Ophthalmic Conclave. We have a great session ahead about with complex strabismus cases, the current trends. We have stalwarts from all over the globe who are going to be taking some interesting topics and some case presentations following that. I would invite Dr. David Granite to give the open remarks of the session. Over to you, sir.
Thank you so much. I don't really want to take up a lot of time except to say thank you to the AIOS and the World Society of Pediatric Ophthalmology and Strabismus for being so easy to work with together and make this possible. This is really exciting for us representing WSPOS today to be able to put this group of people together. This is really a phenomenal group. Ramesh Kekanoya will not be fully available today, and Dr. Sawe Leo will be helping work with us in terms of moderating it. So I'm going to get out of the way after thanking everybody in advance for all your great work and for all your efforts, and I'm looking forward to learning with everyone else. Sawe?
Yes, welcome everyone. I'm going to share the slides quickly. Okay, so could you see all my slides here?
No, we can't see your slides now.
Could you wait? Let's.
Sawe, while you're putting those up, I see Ramesh Kekanoya is here. Ramesh,
Okay, so maybe
from San Diego, from around the world. We have people, and I don't know if you want to say hi to everybody and welcome.
Yeah, thank you, everyone. I would like to say thank you to each one of you for accepting this invitation. I think it's a fantastic group of we have. I would like to thank Showe. You know, sometimes emergencies, the friends help. Showe is a pediatric ophthalmologist well known around the world, and she was in NEI Singapore. Before joining, now she's in pediatric ophthalmology private practice in Singapore. She is also an executive bureau member of the World Society of Pediatric Ophthalmology, and she has graciously accepted to be a moderator for this session. And thank you so much, Showe. And I'm here around. I had a conflicting kind of commitment which has come recently, so I'll be on and off. And thank you for taking this up. And over to you, Showe.
Okay. I would welcome my two chairpersons, Dr. David Granite from San Diego and Professor Pradit Sharma from India. We're very, very honored to have four speakers today with us. Dr. Andrea Molinari from Ecuador, Professor David Hunter from Boston, Robert Clark from California, and Dr. Shatha Farahi from Saudi Arabia. And we have our panelists, my fellow panelists, Dr. Jyoti Matalia from Bangalore, Dr. Yai Murad from Israel, and Dr. Suma Ganesh from New Delhi. And I'm also looking forward to the case presentations by our four young fellows, Dr. Gopinda Nair, Dr. Dewan, Dr. Rajendran from India, and Dr. Katerina Gonadi from Singapore. So I would like to just welcome everyone to our upcoming webinars. With WSPOS, we're going to talk about amblyopia and cystinosis. And please do join us at WSPOS where membership is free. So thank you, audience, and let's get going.
So, you want to introduce our first speaker?
Okay, so in the interest of time, the first speaker is Dr. Andrea Molinari from Ecuador. She's going to talk to us about accessory extraocular muscle, how it works, and so on.
Thank you so much for having me here today. Hello, everybody. And I'm opening my slides. I hope you will see them shortly. And thank you for inviting me to present on this topic, which interested me very much some time ago, on accessory extraocular muscles. Accessory or supernumerary structures can be found in many parts of the body, and the extraocular muscles are no exception. You might think that these might be very infrequently seen, and yes, they are pretty rare. But in this published paper by Kitry and Diemer in 2010, where they evaluated over 500 orbital MRIs in patients with and without strabismus, they found 12 cases with these anomalous orbital structures. Curiously, only in 2 of them, these structures seem to be responsible for the ocular motility disorder. And notably, in 6 of these 12 cases, they had some type of cranial congenital degeneration disorders, which makes us think that maybe these structures are the result of an anomalous innervation of the primitive extraocular muscles during embryogenesis. Another very interesting theory about these structures is what has been published by these several authors, that these structures are an atavistic remnant of a muscle found in lower mammals called a retractor bulbi, which is a muscle that retracts the bulb. This muscle appears from the orbital apex and goes underneath the other extraocular muscles. Greg Luder, in his very comprehensive review of these anomalous orbital structures, divides them in 3 different groups. Structures that are arising from the extraocular muscles themselves, inserts in anomalous location, like in this picture here, published by a German anatomist called Michael von Lüdinghausen, where you can see this structure connecting the superior rectus to the inferior rectus and then running towards the orbital apex. Fibrous bands located beneath the rectus muscles. These are more commonly seen, especially in Duane syndromes, or as in this case that had a congenital fibrosis of the extraocular muscles. I am hooking there the inferior rectus, and as you can see next to inferior rectus is this band that the patient had. And the last group are discrete anomalous structures that arise from the posterior orbital apex and insert in the posterior aspect of the sclera. Many of these structures also connect to some other extraocular muscles. And to this last group belongs this series of 7 patients coming from different parts of the world that we published in 2016. All these cases, as you can see, share the same clinical characteristics of anophthalmos and variable ocular movement restriction in the affected eye. Also, all of these cases had this anomalous structure found in the posterior orbit that inserted very close to the optic nerve and run towards the orbital apex. Let me describe you one of these cases. This is a child I saw for the first time when he was 2 years old, and the parents complained because they noticed that the left eye was smaller and could not move very well. At this time, I misdiagnosed this case as having a Duane syndrome. I saw him again 2 years later. The left eye looked even smaller. And then I noticed that the movement restriction was not only horizontal, but also vertical. And the patient had an anophthalmos that was present in all gaze positions. This is when I asked for an orbital image. And the orbital image demonstrated this anomalous structure behind the globe, inserted very close to the optic nerve. Here you can see it a little better. This structure ran towards the orbital apex and also had a connection to the lateral rectus. In the corneal cut, You could also see that the structure was very, very close to the optic nerve, as was described by another German anatomist, Fleischer, in 1907, where he described that this structure had muscle fibers, same muscle fibers as found in the other extraocular muscles. So I did surgery on this child. As you can see, the traction test was very positive. The lateral rectus seemed very abnormal, like the muscles you see in congenital fibrosis of extraocular muscles with very enlarged vessels on its surface. And after disinserting the lateral rectus, which was not very easy because it was very tight, but you can see that after disinserting the muscle, the traction test was still very positive. And then the muscle was inserted a little bit farther back than in its normal insertion. And when exploring the posterior orbit, I could see this part here, which is the same as this part here. It was the tissue connecting the posterior globe with the lateral rectus. It looked more like a tendinous band, but it was this accessory structure. There you can see me hooking this structure, which was very, very, very tight. And then I decided to cut this structure to see if I could release some of the positive traction test. But even after cutting this structure, the motility did not improve much, the passive motility. And the child was pretty much the same as it was before the surgery. So to conclude, these cases are rare, and they are usually misdiagnosed as Duane syndrome cases or as congenital fibrosis of the extraocular muscles or Brown syndromes. But they present with anophthalmos in all gaze positions, not just in certain positions. The ocular restriction is very variable, can be variable, but is mostly very restricted. And orbital imaging is really crucial for diagnosing these cases. Finally, I would like to take this opportunity to invite all of you to the next ISA meeting in November in Buenos Aires next year. Follow us, and thank you so much for the kind attention. Let me stop sharing my screen.
Yep.
Andrea, that was magnificent. Thank you so much. We're going to take the next talk and then a whole bunch of questions and discussion after that. David Hunter is going to straighten us out on how to deal with orthophoric patients.
Great, thank you very much. And let me share my screen. Thanks so much for it. Oh, did I include the right? Hang on, let me do that again. Share my screen. Choose the right one. There we go. Okay, there we go. Thanks so much for including me. This is, I want to talk about doing strabismus surgery in orthophoric patients, or I like to call it straightforward strabismus. This is something that I never really asked for, but it has come to pass, and any of us who do strabismus surgery will eventually encounter patients who have these difficulties. I want to thank Dr. Fanfruck, who did a lot of the details behind this, and I have financial disclosures of not relevance to this presentation. So why would anybody do strabismus surgery on a patient with straight eyes? Well, there are several reasons. One is that it isn't just primary gaze that's important to a lot of us. For example, this lacrosse player needs to see straight ahead, but she also needs to be able to use her eye contact to look off to the right and to look off to the left and to maintain a good view of what is happening all around her. Second is during driving. Sure, it can be single straight ahead, but if you're looking off to the side and trying to pass someone, that can be a problem. I had one patient who said, I feel like I'm stuck in a box, because she had straight eyes looking straight ahead and only looking straight ahead. So these are some of the reasons that we look into this. Here's an example, a patient who's ortho in many gaze directions, but esotropic in left gaze and hypertropic in down gaze. Symptomatic from this, really, impaired and wanting to do something about it. Now, in these cases, we can't say this. One of the things when we look back at these is you can't just say success is ET less than 10 and XT less than 10. Like that doesn't work in these cases. So we developed an incompetence measure that that I don't have time to go into specifically today, but a way to measure incompetence. So then how do you assess outcomes? Well, first is do no harm. Did we do any harm? So a lack of a new primary gaze deviation, a lack of a new compensatory head posture. That would be a bad outcome and something that could cause more than a bad outcome looking backwards. I was fine before. Anyway, second is improving the measurements. And this is where we look at this incompetence score that we developed, and also the size and centration of the field of binocular single vision. Unfortunately, despite doing this a lot more frequently now, we don't routinely get fields of binocular single vision, so we rely on the incompetence score. Third is subjective improvement, and this is the softest measure, but we had to have something to go on. That's patient satisfaction, the surgeon, namely me, saying whether I thought it was a good postoperative alignment, and improvement in gaze to the more symptomatic side. So that's how we measure it. No harm, improved measurements, subjective improvement. And so looking backwards, I have 4 surgical strategies that try to meet these measures when we look at it. So strategy 1 is simultaneous recession of ipsilateral antagonist rectus muscles. So for example, if the right eye is not moving but up or down, but we want to reduce the movement of the left eye, we could potentially recess significantly the superior and inferior rectus muscles to somewhat reduce the extent of range of the eye on the left side to match the deficit. Strategy 2 is resection or recession of one rectus muscle with balancing surgery on the fellow eye. So, for example, we have a problem in one direction, we recess the inferior rectus muscle on the right side. That's going to move the eye up. And so to account for that, we resect the superior rectus muscle on the other eye to move that eye up also and change what happens in eccentric gaze. The third strategy is combining a resection and recession of one muscle. That is a non-adjustable Faden operation. So that, for example, if we resect a big piece of the lateral rectus muscle 10 millimeters and then recess it 10 millimeters, then it's not going to move that left eye as far to the left. That can help account for a deficit on the right eye. And then strategy 4 is to create an acceptable, adjustable new deviation in primary gaze. So that is, go ahead and do the surgery on one muscle and see if the new deviation in primary gaze is tolerable. That's for A. For B is doing a micro recession, a snip recession of one rectus muscle, and hoping you don't get a deficit. Hoping, but making it adjustable so that if you do get a deficit, you can always reverse it. So those are the strategies. We look back at patients who I operated on over 11 years who met the criteria. So we have a broader group where we just looked at microstrabismus, less than 4 prism diopters vertical, less than 5 horizontal before surgery, and who had sufficient follow-up. So we had 32 of those, but then of those 32, we had 12 who were orthophoric in primary gaze. So of those orthophoric patients, 8 had symptomatic vertical or horizontal incompetence in different gaze directions, but then we had a subclass who had symptomatic esotropy in lateral gaze only, and those were patients who had previously had lateral rectus recessions. So that's the group. So to show you an example first of the first group, a 71-year-old woman. She had a traumatic left orbital 4 fracture. She had double vision in left gaze, down gaze, up gaze, but was ortho in primary gaze. So, and disabled by the double vision. So here's where she was ortho. In left gaze, ET 10, in down gaze, left hyper of 8. So what do we do about that? Well, for the vertical, for the horizontal, I actually didn't do an adjustable FODN. I just did a good old straightforward FODN operation for the horizontal for left gaze. But for down gaze, I did a combined resection and recession of the inferior rectus muscle. That's surgical strategy number 3, the adjustable FODN. But then I also did a adjustable left inferior rectus recession, which is to balance any effect of the increased recession on the other eye. So, and then I, again, as I mentioned, did a posterior fixation suture on the right medial rectus muscle. And so with that combination, we took care of the horizontal. In left gaze, we took care of the vertical. The incompetence score that I didn't describe you exactly improved accordingly. So that is, so the patient assessment was, the patient was very happy with the results, and the surgeon assessment was excellent. All right, so we have time for at least one more case. This patient had lateral gaze esotropia. This is that second group after bilateral lateral rectus recession. So 15-year-old girl, esotropia in right and left gazes, previous 7.5 millimeter recessions, and she had a V pattern as well. Let's see, I think I've got there we go. So what to do for her? Well, for her, I use this surgical strategy 4, which is basically advance the lateral rectus muscles that were previously recessed and try to find the right balance that doesn't give too much exotropia back in primary gaze. So I did bilateral lateral rectus advancements of 2 and 3 millimeters, hoping to restore abduction and create an acceptable deviation in primary gaze. What happened in this and in pretty much all of these patients is that the esotropia improved in lateral gaze, the incompetence improved, but the patient did not end up exotropic in primary gaze. And so thus the good result. So let's see, got a minute and a half. So one more case, 7-year-old girl with Brown syndrome, left hypertrophy and down gaze. She'd already had a left superior oblique tenotomy with vertical diplopia, significant vertical diplopia and down gaze. This one wasn't one of the orthophoric, but it was a rather dramatic increase in vertical deviation in down gaze. And so for her, surgical strategy number 1, simultaneous recession of ipsilateral antagonist rectus muscles. So that's a completion of the left superior oblique tenotomy and the left inferior oblique myectomy. So antagonist muscles weakening on one eye, and then also balancing the deviation in the opposite eye and creating a possible acceptable deviation in primary gaze by recessing the inferior rectus muscle 6 millimeters. And so patients in my presentation, she came out well as a result of that intervention. So that was just a big inferior rectus recession on the right, but also sort of balancing surgery on the left. So overall, out of the 32 patients, we pretty much met no harm. There were 2 out of the 32, this is all of them, who had a new deviation in primary gaze, but they maintained satisfactory control and had no symptomatic diplopia. So no new head postures, and the measurements improved with the incompetence score overall in the 32 and subjective improvement, which is a very soft result, obviously. So in conclusion, it is possible to improve these symptomatic patients by using careful surgical strategies that take care to preserve primary gaze alignment, or at least use adjustable sutures to make sure you can preserve it in the postoperative period. Thank you again for including me. I really appreciate being a part of this session.
Wow. Okay, so I'm sure everyone has tons of questions. I'm looking down at my list of questions. I have like a page full of things to ask everybody. Andrea, can I start with you just real quick? Is that it's been it's been suggested that orthopedic surgeons would never operate on your knee without doing a scan. Yet as strabismus surgeons, we often are operating without getting scans. And so I'm wondering how you separate out and to give us some guidelines on who you would scan, one, and number two is do you ever get into the position where you feel like you're so deep in the orbit that you're uncomfortable and you'd want some other help from either, I don't know, ENT or an oculoplastic surgeon?
Bring your first question. I use orbital imaging a lot, and not in these cases. I think it's mandatory when you have such a restrictive strabismus that is atypical with this enophthalmos. It's mandatory to ask for orbital imaging. I also ask for orbital imaging very frequently in cases of trauma of the extraocular muscles. And there are also many other situations where orbital imaging is very useful. So I think orbital imaging is a very big ally of our work. And regarding your second question was on.
I was asking if you ever get so deep in the orbit that you feel like you
Oh,
might
yes.
want someone else to be
Well,
assisting you.
Since in Ecuador we don't have orbital surgeons, we get used to work very deep in the orbit. I remember once I had a patient in an orbis mission with a trauma that had a lacerated inferior rectus, and I found the proximal stump inserted only 4 millimeters away from the optic nerve, and I had to retrieve it and suture it back. So if you have the help of other professionals like orbital surgeons or ENT, that's great. But if you don't, you have to do it yourself.
Wonderful. And then, David, one quick question from me to you, and then we'll throw it open to everybody for Salway to bounce around. And I'm not sure if Pradeep has some questions, but some of what you discussed, or much of what you discussed, involved going to the fellow eye, and in part limiting the motion, the movement of the fellow eye. In my experience, patients look at you askance when you start talking about limiting the movement of a normal eye. How do you deal with that?
Well, so when patients are really like absolutely do not touch my other eye, there's not a lot you can do, but there is one thing you can do, which is to say, okay, I'm going to try to operate on your left eye. Let's see what we can get. But if that doesn't work, then the only thing we can do is to operate on your other eye. That gives them time to, I guess grieve isn't the right word, but to process this idea and to go through having more surgery, and then the surgery doesn't work, and now they have to decide, like now they have a decision to make that's yeah, that you understand. It gives them time to process, and some of them will say no, absolutely not, sorry, thank you. But usually by talking about balance, by talking about the other eye's overcompensating, by reassuring that don't worry, this eye is still going to move. You're not going to notice a difference, but it's just enough to balance so that it's the same force to look over to the left. We have to, I can't make it move to this eye move to the left any better. I can't make less scarring with more surgery. I use that a lot. Can't make less scarring with more surgery. So the only way to balance it is to go to this side. I also,
usually, Sorry, and
Oh, go ahead.
usually, if I may add it, if the patient usually comes because the patient is very bothered because of the diplopia. So if you tell them you have to trade one thing, the relieving your diplopia for having a little bit of restriction on the other side, they will accept this.
Yeah, or saying, okay, the box of single vision is over here, but we can move it over here, but only by working on your other eye. Also on, if I can, on Andrea's comment, one thing that I have been doing in these orbital cases, once we have the imaging, is we have a facility where we can 3D print the we 3D print the orbit in a multitude of colors, and so we've used that to sort of plan and strategize, like, are we going to go lateral or medial? Do we need to take off bone or do we not need to take off bone to get to where we need to go?
If I may add a word about Andrea Molinari's presentation, I think it's really crucial in every case that we do to do the force reduction test at the end and look for any other restrictions in movement of the globe. And if you see that, we have the retractors that we have in our normal strabismus set, the Maurer retractors and so on, are really limited. So we can ask a set of our ocular or plastic surgeons or ocular surgeons. They have magnificent retractors that can really let us go deep and look for strands and look for extraocular muscles way back, even near the optic nerve, as you said, and never give up. If the globe is not moving well, you should try to find why. This is my advice.
I think that makes sense, that you have to depend on the force reduction test at every step of the surgery, and definitely at the end of the surgery, you should do a force reduction test to see that the globe is freely moving. Otherwise, the job is not done. So that's correct. Dr. David, I mean, I think it was very interesting talk to listen, and it's from the outside it appears like a sensational topic, but because we are talking of orthophoria surgery. But there are situations in which we do orthophoria surgery other than what you mentioned, like maybe ortho-DRS cases, ortho-Duane's retraction syndromes, or in cases when we are doing an eccentric null shifting in nystagmus cases, then we have to ensure that we have an orthophoria maintained in the position that we want to shift, or maybe the pure V patterns that we are operating on the obliques, but we are ensuring that the horizontal position in the primary position remains good. The question that I had for you was, I saw that some of the situations you were still tackling, like superior oblique tenotomies or inferior oblique myectomies. I was wondering, I mean, in situations which are so delicate or demanding, would it be, I mean, these things would be like little less controlled. So would you like to prefer to do more controlled procedures like recessions or the controlled weakening procedures on the obliques?
Sometimes that's fine. Yes, sometimes that's certainly necessary, but but if you take another example of operating on an orthophoric patient that I didn't include is superior oblique myokymia. And in those cases, you have to do superior oblique tenotomy. You can't do a graded tenotomy, or there's still going to be a connection to the globe, and so then you need to do an inferior oblique myectomy as well. And so, having done several of those in recent years, and I've been amazed at how over time the competence is like fully restored. Like the patients are able to, yes, there's transient double vision and lateral gaze, but they actually get better. And so I've been wondering the opposite of whether in Brown syndrome, are we overthinking Brown syndrome? And would we be better off just doing superior oblique tenotomy and inferior oblique myectomy in Brown syndrome? I'm not necessarily advocating for that, but that's the way we did it in the old days before we started putting in things, the sutures and
that's interesting.
One question I had regarding orbital imaging, Dr. Andrea, is there any specific thing that you order for the orbital imaging?
Yes, well, if you can order for an MRI, it's much better than a CAT scan. And also always ask for small cuts and fat suppression and different cuts, sagittal and coronal and axial.
Actually, I have to ask for no fat suppression. I think you can see the muscles better with no fat suppression.
Really?
Interesting. Because they always do fat suppression if you don't ask them not to. Huh.
Okay.
It's two different views.
And coaxial cuts as well help as well. If you can ask your radiologist to take coaxial cuts, that would help as well in looking at muscle sizes.
Okay. I think we need to move on in the interest of time. So I'm gonna get the third speaker, Dr. Robert Clark, to talk about a review of Pulley surgical techniques.
Thank you guys for inviting me to speak. Can you guys see my screen now? I'm going to review Pulley surgery techniques. These are my disclosures. The grant support is relevant to this topic. Here's a list of my many research collaborators on this topic. I especially want to acknowledge my longtime mentor and colleague, Dr. Joseph Deemer, and my good friend and top innovator in strabismus surgery, Irene Ludwig. I'm going to review the extraocular muscle pulley anatomy, then describe common and uncommon motility disorders that can be caused by pulley abnormalities, and then get into the surgical techniques that directly involve the pulley structures to correct these disorders. All of the extraocular muscles, except for the superior oblique, have soft tissue pulleys. The pulleys contain a mixture of collagen, elastin, and smooth muscle, and serve an important biomechanical function by constraining side slip of the posterior muscle path. The pulley keeps the posterior muscle blade in alignment with the muscle's insertion, so the muscle can properly generate force into its field of action. This series of histology slides of a whole human left orbit demonstrates the connective structures that surround the extraocular muscles. Blue stains collagen, and pink and red stains muscle fibers. Starting at the orbital apex and extending to the mid-orbit, each muscle belly is surrounded by orbital fat without much support. Beginning near the posterior border of the globe, bands of collagen begin to envelop each muscle, intermingling with smaller amounts of smooth muscle. The pulley tissue is thickest around the medial rectus, then inferior rectus, then superior rectus. It is weakest around the lateral rectus, but also includes this supporting band between the superior rectus and lateral rectus called the LRSR band. MRI of a left human orbit through the same region shows that, except for the densest tissue, like the LRSR band and some of the bands around the medial rectus, the pulley tissue is not easy to image. So when we talk about displacements of extraocular muscle pulleys, we usually talk about displacements of the posterior muscle bellies on imaging that define the location of pulleys. Normally, the posterior muscle bellies are fairly symmetrically aligned with their antagonists across the midpoint of the globe. A tangential displacement more than 2 to 3 millimeters from this location can introduce destabilizing forces that degrade motility. The other anatomical feature that is important to this talk are the two longitudinal layers of each extraocular muscle, the global and orbital layers. The internal half of each muscle, the part that's closest to the center of the orbit, passes through the muscle pulley to insert onto the globe. This global layer directly rotates the globe. The external half, the orbital layer, inserts onto the muscle pulley. It does not continue onto the globe. This orbital layer shifts the pulley posterior during contraction and anterior during relaxation. High resolution of the medial rectus insertion reveals the longitudinal split in the muscle belly near the insertion. And the orbital fibers can be seen to insert onto the medial rectus pulley as reflected anteriorly by this Damar retractor. This busy slide encompasses all the important anatomic feature. Each muscle is divided longitudinally into orbital and global layers and is enveloped by a connective tissue pulley. Now we discuss pulley disorders that can contribute to motility disorders. The first and most important disorder is sagging eye syndrome, which has become the dominant cause of misalignment problems in older adults. Remember, the lateral rectus has the flimsiest pulley, but it has a dense band of support, the LRSR band from the superior rectus. Unfortunately, as this series of orbital cellular studies demonstrates, the LRSR band atrophies with aging until it's almost non-existent in the very old. On imaging, the top border of the lateral rectus muscle is inferior to the globe equator. It has sagged enough to cause a motility problem. In the left orbit, the lateral rectus is the correct position, while in the right orbit, it has sagged enough to create a motility disorder. This 85-year-old female had an acute onset of left hypotropia with a severe elevation deficit. The pupil asymmetry is an incidental finding. she had a more severe sag of the left lateral rectus, converting into a depressor of the eye that limits up gaze. This middle-aged man appears to have a Brown syndrome, with impaired elevation of the left eye in adduction, with better elevation in abduction. Instead, he had an unstable location of his left lateral rectus. During abduction, it slides inferiorly to tether the eye down, just like the prior case. But during abduction, it shifts superiorly to near the normal position to allow better upgaze. Another Pulley disorder is heavy eye syndrome. Here is a combination of high myopia with axial elongation associated with esotropia and hypotropia. In many cases, the eye appears stuck down and in. Imaging typically reveals that the enlarged globe has herniated through the LRSR band, leading to more severe Pulley abnormalities. The lateral rectus is clearly inferior, tethering the eye down, but the superior rectus and inferior rectus are medially displaced, adding to the esotropia. These conditions are all best addressed with some form of Pulley surgery. The goals of surgery are to restore normal Pulley location and function, minimize surgical trauma to the muscles, and reduce surgical risk by minimizing sutures to the globe. Because these surgeries directly correct the anatomic defect causing the strabismus, they are potentially more effective than standard muscle surgeries that strengthen or weaken muscles to indirectly compensate for the defect. And if they're performed cleanly with minimal dissection, they can cause less scarring and thus are potentially more reversible than standard muscle surgery. The first surgeries that involved Pulley anatomy were transpositions of the extraocular muscle insertions. Since the pulleys are specifically designed to resist side slip and prevent redirection of muscle force away from the field of action, the original transposition surgeries were not particularly effective. The first surgery specifically designed to directly involve the pulley is Pulley posterior fixation. We created this surgery based on an earlier study that showed the mechanical effects of posterior fixation was not the loss of arc contact, but rather a mechanical collision between the posterior suture and pulley sleeve. If the arc of contact is not important, why suture the sclera? The initial steps of Pulley surgery are exactly the same as for standard strabismus surgery. In this case, the medial rectus has been isolated through a limbal incision and recessed. Next, a muscle hook is slid posteriorly along the anterior muscle belly, then rotating the hook anteriorly, it's pulled forward to hook the anterior portion of the medial rectus pulley. The medial rectus pulley can then be secured by placing a permanent suture through in a backhand fashion, directing the needle away from the globe. Now the anterior medial rectus pulley is secured on a suture. Next, the suture is placed to the inferior 1/3 of the medial rectus muscle belly, right where it enters the pulley sleeve. When tied permanently, this suture, without a scleral clasp, creates a mechanical restriction to adduction that defines the posterior fixation effect. Pulley posterior fixation has been around for more than 20 years and is quite effective, but creative surgeons like Irene Lugwood asked a simple question. Now that we have the medial rectus pulley secured on a permanent suture, why just suture to the adjacent medial rectus belly for posterior fixation? Where else could that suture go? How about using that suture to transpose the posterior muscle belly and thus the pulling direction of the muscle, either directly to the sclera for a pulleypexy or onto the adjacent pulley to create a pulley sleeve fusion? Theoretically, we could augment and transvest the insertion without traumatizing the posterior muscle belly. Or how about advancing the pulley sleeve towards the muscle's insertion? The combination of passive tension from stretching the pulley connective tissue combined with active contraction of the orbital layer should dramatically increase the effect of any planned plication or resection. In fact, Dr. Lugwood has used this lamellar advancement technique to strengthen the medial rectus to correct large deviations in convergence insufficiency exotropia without repositioning the muscle's insertion. Finally, how about switching the pulley to the periosteum to create a tether to reduce the muscle range of motion? This technique can be used instead of posterior fixation for extraocular muscles with relatively flimsy pulley sleeves, like the lateral rectus, because it can create a stronger positive force suction than can be created by collision between the suture and the flimsy pulley. How would these pulley surgeries work in clinical practice? This patient had a sagging lateral rectus muscle. In 2016, we described equatorial myopexy, a simple technique where we sutured the superior 1/3 of the posterior lateral rectus belly to the sclera in the supratemporal quadrant near the equator to pull the posterior muscle belly superiorly. This procedure works wonderfully well in most patients, but it can be difficult to take down because the anterior lateral rectus muscle can become fused with the sclera. It also does not work as well for more posterior and severe sagging. Instead, we could have performed a pulleypexy by suturing the pulley, not the muscle belly, to the sclera or to the adjacent suprarectus pulley to achieve the same effect without traumatizing the muscle belly. These intraoperative photos are from that 85-year-old female with a more severe lateral rectus inflammation. Here, suture posterior bellies of the lateral rectus superficial with 2 interrupted sutures because the first suture was not enough to close the gap. We could have achieved a similar result performing a pulley sleeve fusion with less tension distortion of the anterior muscle bellies. Post-operatively, she has much better alignment in primary gaze and much better elevation without repositioning any of the muscles insertions. In conclusion, pulley surgery is an exciting and rapidly evolving area of strabismus surgery. Consistently strong effects are only possible if there is sufficient connective strength within the pulley to achieve the desired mechanical effect. You will need to use permanent sutures, and the tissues do not naturally bond to each other. Plus, there is a limited ability to titrate the effects. Finally, these procedures have not been used for that many years, so the long-term success rates are unknown. Thank you for your attention.
Thank you, Dr. Clark. I have a question for you. Like, how does age, in your experience, how does age affect the pulleys, and is it different between your horizontal and vertical muscle pulleys in your experience?
Age has a very dramatic effect on both the pulleys and also the surrounding tissues that support the pulleys. So older patients tend to have more flimsy pulleys. So trying to do posterior fixation in the very elderly is not as successful as in the young. That's why a lot of our pulley fixation surgeries are most effective in children with the high AC over A ratio. Now, in terms of how to reposition the muscles, I'm trying to progress from just tying the muscles down to using more pulley surgery because it is less traumatic. However, it can be difficult sometimes to grab enough pulley tissue to make a firm.
That way it looks like he's frozen.
Yeah.
Oh. Why don't we go ahead?
Dr. Clark, we lost you for a bit. You want to just repeat the last bit? Yeah.
I would say that, can you hear me now?
Yes.
Okay, so basically in the elderly, the pulley connective tissue is not as well defined as in the young patients. And so the effect of many procedures such as posterior fixation are not as effective in older patients. I went more to using muscles themselves directly to the sclera, but that's difficult to reverse. And so now I'm trying to be more aggressive, trying to find more posterior pulley tissue to achieve the same effect without actually traumatizing the posterior muscle belly.
Thank you. Does anyone else have a question? If not, then we could go on to the next speaker.
So if we're going to take questions now, I'm guessing that Yair Murad wants to comment, given the fact that he just had a publication on this topic using a different approach. Yair?
Yes, thank you. Well, I think this approach is very good, very positive. The only thing is, as you said, since many of our patients are at the older age and their pulleys are really flimsy and very atrophic, sometimes I feel that this will not work. And this is why I personally, since for sagging eye, prefer to do what we call superior plication. I plicate only the superior half of the lateral rectus forward. I think I showed it in one of the meetings with Irene Ludwig. I think you were there. I found it very useful, and I'm going to present that in the next APOS. 30 cases of almost more than 90% success.
Yeah, the interesting thing about the sagging eye part is it's not just the pulley that's kind of floppy. It's also the muscle belly itself. The muscle belly is elongated in the older compared to the younger patients over here. So in many of these patients, especially with larger angles, the just repositioning the pulley itself is not going to be enough. The muscle still has too much slack. And so then if you want to go ahead and do a tightening procedure, plication is a nice technique because you don't sacrifice the vasculature. And if you do it asymmetrically, you can create some sag. So usually a combination approach. You're trying to suspend the pulley as well as asymmetric advancement of the muscle belly can achieve a pretty good effect.
Robert, one of the things that we showed was that the inferior rectus, and you can see it in all the pictures you showed, the inferior rectus shifts as well as the superior rectus most of the time. And you end up with a medial rectus, an inferior rectus, and a superior rectus all on the nasal side of the eye. And so I think that's part of why the amount of surgery to do, in addition to the floppier, quote unquote, lateral rectus, becomes a little bit more complex in trying to understand how to approach these patients, and why when people go ahead, it's more than just the fact when you're recessing the medial rectus, you have to do more because the vector force changes from the lateral rectus. I think there's more than that happening. And that shift that you see by shifting the lateral rectus and the pulley goes to the heart of some of the actual physiologic issues.
Yeah, I agree. You're talking about for just sagging eye, not just the heavy eye, correct? Sagging eye syndrome?
Correct.
Right. I've always been very curious to why people would do such a large medial rectus recession. Basically, you're almost like working against a paretic lateral rectus. You have to double and triple your dose on the medial rectus, where you should take up the slack. Or at the very least, you should at least plicate the lateral rectus to remove some of the slack, as well as reposition the pulley, and that's much more physiologic. In my hands, it tends to be much more durable.
Yeah, and it works.
Yeah,
Right.
I agree. In some cases, you may not have to do MR recession at all.
Correct. In most cases, right? I rarely do an MR recession for this
Exactly.
exact
You can
syndrome.
pick them early.
I just put one medial rectus on adjustables just in case, and I really need to move it.
Right. You are a belt and suspenders young man.
Very nice.
Okay, can we have now we have Dr. Shatha to talk about superior oblique lengthening procedure.
Okay, can you see my slides?
Yep.
Okay, great. I would like to thank the organizing committee for inviting me to give this talk. The title of my presentation is Superior Oblique Split Lengthening Procedure. So this procedure is usually done for Brown syndrome. A little bit about Brown syndrome. It was described by Harold Brown in 1950 as a motility disorder characterized by restriction of active and passive elevation and adduction. So not every Brown syndrome requires surgical management. However, when you have amblyopia or large vertical deviation, or you have an abnormal head position, you need to treat this. So this was in a publication from the American Journal of Ophthalmology by Crawford in 1976. And I thought it was very interesting that he mentioned split lengthening procedure in this paper. As you can see here from his drawing, he mentioned and drew the split lengthening procedure in his publication. So there are so many described surgeries in the literature to weaken the superior oblique in particular. So to name a few: Z tenotomy, complete tenotomy or tenectomy, adjustable suture spacer, or chicken suture, where the ends are sutured with a permanent suture to prevent the superior oblique palsy that happens afterward, or recently a thinning procedure that was described from Dr. Zeo from Spain, where she thins the superior oblique tendon, or the spacer technique, which was described by Dr. Kenwright in 1991, and the superior oblique split lengthening procedure. So these procedures, complete tenotomy and tenectomy, have a superior oblique palsy. Sorry, it looks like it's flipped from keynote to PowerPoint. So it's superior oblique palsy. It carries a risk of superior oblique palsy in 50% of those patients. And even in some literature, it was up to 80% as well, developing superior oblique palsy after a tenotomy or tenectomy. The problem with the spacer as well is the extrusion or infection as you insert a foreign material into the orbit. And all of them can cause under or overcorrection. So the search of a better procedure to treat Brown syndrome is still ongoing and evolving. So this is my technique. I basically split the length of the tendon. In short, I place sutures over an upper and lower half of the superior oblique tendon that's spread between those two hooks, and then I cut on where the dotted line, and then reconnect the two ends to lengthen the tendon. This is the procedure in a video. As you can see, this patient has limitation of elevation of her left eye and better elevation on abduction that confirms the Brown syndrome. Of course, every procedure starts with force section testing. It was negative on the right, and then on the left, I have some difficulty with a positive force section testing. And then I always compare both sides. So I always compare, as you can see, I'm struggling to elevate the left side and confirm the diagnosis. I also use the Guyton exaggerated test, where I'm trying to retropulse and then dial up, and I have some difficulties. So the procedure starts with a superior temporal incision. Some surgeons also go directly to the nasal side, but I prefer the superior temporal approach. I hook the superior rectus first, and then I visualize the insertion of the superior oblique. As you all know, the superior oblique insertion is wide, and I try to hook all the tendons as much as possible from the temporal side, and then I'm hooking it here with a spatula. You can use a spatula or a Stevens hook to try to hook the whole width of the superior oblique tendon. After hooking the superior oblique tendon from the nasal side, I then go to the, from the temporal side, I then go to the nasal side. I spread the tendon with two hooks. I mark my split tendon here is 8 millimeters. And then I place two sutures. I normally use Vicryl sutures. In the literature, a lot of surgeons use permanent suture like Merceline or Proline as well. I use Vicryl and I see no problem with the Vicryl suture. I split the tendon. I place one of the blades of the scissors and gently elongate the split with the two small Stevens hooks, and then I cut the two ends. I cut the lower one first, and then here I'm cutting the top end. And then I reconnect the two halves, elongating the tendon 8 or 10 millimeters. After securing the two halves together and closing my sutures, I repeat force section testing, of course, to confirm that I have hooked the whole tendon. And if I find any restriction, I go back and I look for more tendon. I sever them if I see any more tendon or restriction. And then this is a closure. So the advantages of this procedure is improvement in mean deviation and elevation. It has a low reoperation rate. The results are more predictable and stable over time, as I will mention in the, from my publication and from the literature as well. And the original fan shape insertion of the muscle is preserved, so you maintain its function, and it is performed with a normal tendon and muscle. Thus, you don't really need to worry about extrusion or infection of any material that you place over there to elongate the tendon. So the questions that come in mind for any surgeon before we adopt any new procedure: how much should we split? Which suture material should we use? What are the effects exactly on A pattern, primary deviation, and torsion? And are there any other indications to this procedure? And to answer these questions, I will go over the literature and some of the publications about this procedure in particular. This publication from the British Journal of Ophthalmology from our institution, we looked at our results of 20 patients with Brown syndrome that we elongated the tendon 6 to 10 millimeter apart, and we had a very low rate of overcorrection only in 2 patients, and 1 patient required reoperation, and that 1 patient had 6 millimeter of elongation and it did not improve primary deviation or elevation and adduction, so we had to go back and tenotomize the tendon. This is from our publication. As you can see, this girl has limited elevation of adduction in her right eye, in her left eye, as you can see there, and the eye drops down on that image right there when she adducts her left eye. So we had split her tendon 10 millimeters, and it improved her elevation and adduction, as you can see in B there. There's another publication from Dr. Murad where he elongated 17 eyes of 17 patients with congenital Brown syndrome of 8 millimeter, and he as well found very good results, and that he had a low reoperation rate as well. So it does have some complications, including superior oblique palsy, but it's much lower than a tenotomy or tenectomy. The reports show 5 to 10%. And I believe that it could be from the separation of the two ends, which shifts this procedure to a tenotomy if that happens. Also, there's the risk of scarring in the superior nasal quadrant as well. V pattern can happen as well, and inferior oblique overaction have been reported as well. So what other indications? Well, we can use it to superior oblique overaction in general, to correct torsion as well, A pattern and abnormal head position, as well as Brown syndrome. So this publication from Bardorf and Baker describes the efficacy of superior oblique lengthening on superior oblique overaction in particular. And they found in their publication that superior oblique overaction improved in unilateral cases from +2 to +0.5, and in bilateral cases from +2.5 to -0.6. And the A pattern has completely eliminated in all of their patients to less than 10 prism diopter of difference between up and down gaze. And the change in deviation between primary position and down gaze in unilateral cases was 3.9 prism diopters, and in bilateral cases was 5.4. So as you can see, this is effective in treating superior oblique overaction and A pattern as well. In terms of face turn, in this publication from a group from Italy, they found that their patients with superior oblique overaction and abnormal face turn because of concomitant vertical deviation inside gaze, NXT has improved with elongating the tendon about 8 millimeter as well, from an average face turn of 26 degrees to 5 degrees. So they collapse 15 degrees of face turn, which is great with this procedure. In terms of torsion, this publication from the Indian Journal of Ophthalmology looked at the effect of the superior oblique split lengthening on torsion, and they elongated the tendon from 4 to 7 millimeters, and they noted that the encyclotorsion of the fundus shifted and corrected in most of their patients. This is their preoperative fundus picture, as you can see in the top image with encyclotorsion. There's an excyclorotation torsion effect of this procedure, and they calculated it to be for each millimeter of surgery, an improvement of 0.8 degrees was seen in dilated fundus exam. And in other words, for each 1 degree of improvement required, you need to do 1.2 millimeter of lengthening. So, in conclusion, superior oblique split lengthening improves head posture and eye motility with stable long-term results and limited reported complications. It's a relatively simple procedure. It does not require any synthetic material, and it has very predictable outcomes that are lasting over time. So this concludes my talk. Thank you very much for including me in this presentation. Thank you.
In the interest of time, maybe we can have one question while Dr. Gopinath Nair goes on to get her case ready.
Dr. Shata, I have a question. We all are doing chicken sutures for the, for Brown syndrome or for A pattern. Like, what is the big reason that we should shift to superior oblique, less split tendon lengthening? Like, you feel that any other superiority over this procedure, or only just because of the suture material?
Because of the suture material. So I don't use any synthetic material. I use Bilateral. I know in the literature there are so many other surgeons that prefer to use proline or prefer to use Merceline, I find no problem with using Bilateral, and I find that this is not very hard to learn. And I know tenotomy and tenectomy are very easy. You just cut the tendon and that's it. But I don't use chicken suture or leave any synthetic material. I just elongate the two ends as I showed.
Okay, so maybe we can go on to, in the interest of time, we'll go on to the case presentations. The first presenter is Dr. Gopinath Nair.
Yeah, good evening. Are my slides visible?
Yeah.
Yeah. Good evening. Thank you for inviting me for joining this presentation. My case is regarding a 44-year-old male patient who had presented to us with chief complaint of horizontal recurrent binocular double vision since 1.5 years, which was gradual in onset, intermittent in nature, with maximum separation of images in the right and the left extreme gaze. The patient did not have any complaint of nausea, vomiting, or headache, and this double vision was not accompanied by any diurnal variation. The patient reports a similar history in the year 2009, during which he had intermittent double vision. At that time, he was prescribed prism glasses, but the current patient was still symptomatic despite using these prism glasses. The patient has a rich history of ocular surgery. At the age of 8 years, he has had both eye cryotherapy and lancectomy done for high myopia. At the age of 18 years, he has a history of rhegmatogenous retinal detachment, for which he underwent vitrectomy, belt buckling, and gas tamponade in the left eye. He subsequently developed open-angle glaucoma in both his eyes, which was medically managed. In the year 2012, the patient had a history of intermittent binocular diplopia with right to alternate convergence strabismus with abduction limitation in both his eyes. He was diagnosed with bilateral myopic strabismus fixus elsewhere and underwent a right eye medial rectus recession of 4 millimeters and lateral rectus resection of 7.5 millimeters in the year 2013. At the time, he had a residual esotropia and diplopia, which was managed by prism. The patient also had a history of glaucoma wall surgery in his left eye in the year 2019. Currently, he is on maximum anti-glaucoma medication in both his eyes. This is the anterior segment picture. The patient is bilaterally aphakic and the left AGV tube is quite visible in his left eye, with the AGV sitting in the left superotemporal quadrant. Despite being aphakic, the patient is slightly myopic with the best corrected visual acuity of 618 in right eye and 6/12 in left eye. On examination with contact lens, the patient had a left to alternate convergence strabismus of about 24 prism diopters base out for distance and 20 prism diopters base out for near, with both eyes abduction limitation and elevation limitation. This finding of bilateral myopic strabismus fixus was confirmed on MRI. On his fundus examination, we could see a highly myopic tessellated fundus with the band buckle effect being quite evident in his left eye. Since the patient was able to fuse with prisms, we decided to opt for surgery, with the primary goal being able to elevate the diplopia of the patient, which was quite troublesome. But the real dilemma here was the choice of surgical options. We considered 4 options: a repeat recessive surgery in the right eye with or without Botox augmentation. But the challenge was that it had to be done in a previously operated eye. A loop myopexy in the left eye was deterred due to the presence of the AGV sitting in the superotemporal quadrant, restricting access. A repeat recession could also be done in the left eye, but you have to remember that the belt buckle is still in situ, and a right eye loop myopexy was also considered, but the right lateral rectus was previously resected. Considering all these above 4 options, we decided to go for a left eye medial rectus recession of 6 millimeters, which was done by a hemi-hangback technique. The MR was found to be quite tight in probe. On the post-operative day 1, the patient had a residual esotropia of 10 prism diopters base out for distance and near. However, he was orthotropic with prism glasses and was diplopia-free, and therefore the patient was quite happy, and we achieved our surgical goal. Here, I would like to ask the panelists what their choice of surgery would have been for this patient, and would a right eye loop myopexy would be safe with a resected lateral rectus. Thank you, everyone, for your kind and patient listening.
Wow. Dr. Clark, we heard about scanning, we heard about moving the muscles and pulleys, but now you have an Ahmed valve, and you have glaucoma. How does that change your approach and your thought process when now you have these other issues, including a distortedly large eye and a limited vision eye as well?
The real complicating factor is the Ahmed valve's location. Now, there's different locations for Ahmed valves. This one happens to be in the supratemporal quadrant, which actually adds to the fact that the lateral rectus pulley on that side is infraplaced. And now you have a foreign material that would actually prevent it from being properly placed. So I think trying to avoid that area, unless there was another region, which given he's had prior strabismus surgery, he may not have a better place for the Ahmed valve, is probably a very sound strategy. And we'll talk a little bit about trying to do Pulley surgery on somebody who's already had previous strabismus surgery. One of my very best outcomes was actually on a post-op scleral buckle case who had a very tight medial rectus muscle and a scleral buckle. It turns out that the scar tissue tends to increase the strength of the Pulley tissue, which makes it actually more durable. So I got a 45% upper correction where he was testing 1 medial rectus 2 millimeters with a Pulley posterior fixation in one eye. So it is possible to try to reposition it. You would have to release the scarring around the lateral rectus and then reposition it superiorly. So that would actually be on the right eye, the one that does not have the Ahmed valve. Mm-hmm. And actually the scarring around the lateral rectus, if it's adherent to the globe, it works against you. But if it's just in the connective tissue, it actually can increase the strength of the Pulley tissue. It actually augments the connective tissue, and you can get a little bit more effect than you might otherwise do. So in this case over here, you really kind of have two options. One is kind of the more maximal medial rectus recession, trying to overcome the fact that you have essentially kind of a pseudoparetic lateral rectus on the left side. And the other option would be to go to the right eye and try to restore the anatomy of the lateral rectus on the right side by repositioning it close to the superior rectus, either through a kind of a loop myopexy, do a polypexy, kind of your surgeon's choice based on what you find at the time of surgery.
I completely agree, and I think that probably you'll have to do that eventually, because doing only medial rectus recession on these patients tend not to last very long, and because the sagging downwards continues, and eventually you have to go at least to the lateral rectus in the right eye, not maybe even without any trying to solve the problem of the Ahmed valve and to go to the lateral rectus in the left eye. I agree.
Correct.
Just to add that the resected lateral rectus has nothing to do with the loop myopexy. You can go ahead and do it.
Yeah.
Correct. I guess that's my main point, is that just because you've had previous surgery does not mean you cannot reposition the pulleys afterwards. Go ahead, David.
No, the issue of this Ahmed valve has come up, and we talked about its positioning. We don't want to put it supranasal because you can induce a Brown syndrome. We don't want to put it supratemporal in a high myope. Where do you want to put it? Does anybody want to jump in and suggest for our glaucoma specialist where they should put that valve? We don't like valves, huh?
Well, the trouble with inferior locations is those tend to be more prone to infections and other problems.
Yeah.
So theoretically, you would actually improve the strabismus by putting it infratemporally. You could actually support the lateral rectus by moving it superiorly over here. But I have not seen any valves placed inferiorly. They're almost all as supratemporal, and occasionally supranasally if there's already been a valve done supratemporally.
Okay.
I think with the pressor flow and the lower and the smaller implants they're using nowadays with glaucoma, I think this will not be an issue.
Mm-hmm.
Yeah.
Yeah, hopefully.
Yeah, I think we can move on to the next case then.
Next case.
Good evening, everyone. I hope my slides are visible.
Yes.
So, hello, everyone. My name is Lupavni Diwan. I'm a fellow in pediatric ophthalmology with LV Prasad Eye Institute, and I'm very delighted to be presenting before this esteemed panel. So, I'm going to be talking about fixing the muscle to the bone, that is periosteal fixation of the lateral rectus, specifically in cases of exotropic Duane retraction syndrome. So we know that Duane retraction syndrome represents a very complex interplay of innervational and mechanical abnormalities, where a routine strengthening or weakening procedure of the muscle, where the muscle is attached to the sclera, may not work to fix all the components. And therein comes the role of periosteal fixation, where the lateral rectus is disinserted and inserted onto the orbital wall. So we also know that there is a propensity for contracture of the lateral rectus in cases of exotropic DRS, and this is seen to recur even in cases that have undergone a maximal lateral rectus recession. Also, periosteal fixation helps by abolishing this action completely and thereby removing the unwanted effects of co-contraction and unwanted overshoots on the contralateral gaze. So this procedure has been described successfully for cases of esotropic DRS in combination with a partial vertical rectus transposition, as well as for exotropic DRS with or without a partial vertical rectus transposition. So with that background, I would like to now show two cases. My first patient is a 12-year-old boy who came to us with this picture. This is his 9-gaze image. He had normal visual acuity, anterior segment and fundus examination for both the eyes, and he had maintained a stereo acuity of 140 seconds of arc with a right face turn. So he has a primary gaze exotropia of 40 prism diopters with a dissociated vertical deviation and this severe grade 4 retraction with an upshoot on the contralateral gaze in both the eyes with a pumpkin seed sign seen here in the right eye. So this child was managed with a bilateral LR periosteal fixation with good outcome, and we'll be talking more about that in a minute. For my second case, I have an 18-year-old male who also came to us with a 40 prism diopter exotropia and a -3 adduction limitation along with the abduction limitation. However, he had a very minimal globe retraction and no overshoots. So this patient had no abnormal head posture because of a left eye suppression owing to anisometropic amblyopia. And he initially underwent a bilateral LR recession, which was asymmetric in view of the minimal globe retraction. Post the LR recession, he was seen to have a residual exotropia of 30 prism diopters. And over time, he wanted a second surgical procedure where we chose to go ahead with a left eye MR resection because he had a very minimal globe retraction. Following the MR resection as well, he was seen to have a residual exotropia of 20 prism diopters, and there was a need for a third surgical procedure because this exotropia was maintained at 30 prism diopters even 2.5 years following the second surgery. So this is the procedure that we follow here at our institute. Following hooking of the lateral rectus through a pharyngeal incision, the muscle is seen to be extremely tight here, as we can see. The lateral rectus is anchored with a 4-0 vicryl suture and disinserted from the sclera. And following exposure of the lateral canthus, we take a skin incision just lateral to the lateral canthus around 3 millimeters in length, and following blunt dissection, the periosteum is exposed externally, and the muscle sutures are then exteriorized via the skin incision by making sure that the needle goes through the periosteum of the lateral orbital wall. So following this procedure that was done bilaterally for the first child, we saw good alignment and complete resolution of the overshoots, although mild retraction persisted in the right eye, and the abnormal head posture was also corrected. While for the second case, even though he had multiple failed surgical procedures, following the periosteal fixation in the left eye, he had a satisfactory outcome. So that brings me to the question when to consider periosteal fixation in exotropic DRS. So we look at all these 4 factors. For any exotropic DRS presenting with a large primary gaze exotropia and a -3 or more adduction limitation along with grade 3 or more globe retraction or overshoots, periosteal fixation may be considered as the primary surgical modality for these patients, whereas for patients who have undergone a previous LR recession with a residual large exodeviation, periosteal fixation can come to the rescue. Thank you for the patient listening. And with that, I would like to open for discussion. And these are my questions for the panelists.
Andrea, I'm curious, would you have scanned any of these people for accessory ocular muscles?
Well, there are several papers, especially with exoduanes, that describe finding a very high incidence of bands. But the problem is that the bands are not so easily recognized with orbital imaging. So maybe not. depending on the clinical picture of the patient. But if I may add one more thing, I like this technique of periosteal fixation, and I do the same one. But what I use, which I find more useful, is a baby right needle, the one used for doing suspension in babies, smaller than the regular one. This is much easier to pass than the surgical needle that you have shown.
Just to interrupt, we have a next case also on LR periosteal fixation. If we take the case presentation, we can have the discussion together.
And regarding the accessory things in Duane's retraction syndrome, especially the exo-DRS, many a times what we see is an extra slip of the lateral rectus, which is there. So you have to be careful, and after sizing, you have to see that there is extra slip which needs to be snipped to in Duane's retraction syndrome.
Yeah, I think always checking for that extra slip is always important.
Yeah.
It's very interesting that two lateral rectus and the medial rectus did not help in the second case. We had to put it on the periosteum. There could be two reasons. One is the tightness of the lateral rectus was so much, and it did not allow the adduction. Second thing could be, innovational. So we had to abolishing, that's the word, abolishing that lateral rectus action is very, very important. And it's a balance between not causing esotropia, just having with that. If you have less, that's why when Lubavni showed that grading, only in large angle exotropias we can do that. If the angle of exotropia is less, as Dr. Sharma has published, we might have to do a little bit of partial VRT or SRT to that. So that's the balance we need to create. It's not for everybody. Even my favorite surgery is bilateral asymmetrical recession.
Correct.
These are the two indications we feel it's important. Thank you.
Ramesh, as long as we have you, David Hunter talked about surgery in orthophoric patients. You're taking people and creating an incompetence and making them orthophoric. In my experience, Duane syndrome patients generally don't complain of diplopia and side gaze, but they may be bothered by it and adopt a head position. The incompetence that you're creating in side gaze, to trade that for orthophoria, are your patients generally happy with it? Are they bothered by what they get in side gaze?
You're absolutely right that most of these patients do not have any kind of diplopia. Having said that, I have few patients, Duane patients coming with side gaze diplopias, but I would not do anything. I still very vaguely remember the patient had 25 prisms of esotropia, where the medial rectus was a little bit too much. We did medial rectus recession and superior rectus transposition. Whatever we do, we are not able to correct that consecutive exotropia. So I would not, because many patients come back with that paper, say that, can you do SRT in patients? I would not do that in Duane. Versus in 6 palsy, probably you could attempt that.
Okay, maybe we'll go on to the next Duane's case and then come back to the whole discussion again. So, Dr. Ragasuda, please.
Hi, good evening, everyone. Is my screen visible?
Yes.
Yeah, you can go on.
Thank you. So as we are aware of the Duane's retraction syndrome, let me discuss on the Duane resurgery syndrome, where it was a case of exotropic type of Duane retraction syndrome, which had a required resurgery. So let's talk about an interesting case. It was a 33-year-old gentleman who had a Duane retraction syndrome. And for his abdominal head posture, he had underwent multiple surgeries in the past, to be exact, about 9 in number. And in spite of all these surgeries, the patient was not satisfied and wanted better outcome. So when he had presented to us, the patient had left fixation of about 30 degrees with right eye fixing. And with left eye fixing, he had right exotropia of about 14 prism diopters and right hypertrophy of about 16 prism diopters. And there was a limitation of extraocular movements in his right eye of about -3 abduction and -4 adduction, with the narrowing of the palpebral fissure in right eye on adduction. So these were the surgeries that the patient had underwent from 2009 to 2020, which did not correct his head posture. The patient was not even smart enough to have photographed himself, which had given us an idea. As you can see in all these images, the head posture remained abnormal, and the eye alignment was not corrected too. So we had planned to go about an operative on his right eye. So let's have a look on the surgeries that he had undergone in right eye. So initially, from 2011, he had undergone recession of the bilateral horizontal recti muscle, following which in 2018 he had even the medial rectus was again re-recessed, and the lateral rectus fibrous band resection was done in him, and the recessed MR muscle was again put back to its original insertion, and the resected LR muscle was again recessed, and following which it was fixated to the periosteum, and in 2020 the advanced MR muscle was again resected. So we initially thought we'll do an MRI imaging of the orbit, which had showed that few fibrous attachments from the lateral rectus to the globe. So our initial plan was to explore on table and to remove the remnant attachments of the lateral rectus, and to go ahead if needed with the MR resection along with inferior rectus plication. And on table, on force section test, we found that the lateral rectus and the inferior rectus muscle were tight. And also along with that, the lateral rectus muscle was seen to be attached in the inferior orbital margin and not to the lateral orbital wall. And also the inferior oblique muscle was seen to be dragged along the inferior orbital margin anterior to the lateral rectus, which could have happened during the hooking of the lateral rectus muscle from the previous surgery. So what we did was the insertion of the lateral rectus muscle, and it was later fixed to the lateral orbital wall, along with the inferior oblique myectomy in the right eye was done. So let me explain about this technique of surgery. So for that, let's go into another patient who had undergone a similar surgery. So this was a 25-year-old male who was a known case of Duane retraction syndrome of exotropic type, who had face turn and squint since childhood. As you can see, the patient has right face turn with left exotropia. And the patient also gets previous surgery in the left eye, where the left eye lateral rectus was recessed with Y split of about 9 mm recession was done in lateral rectus, and the MR muscle was resected of about 6 mm and again recessed to 6 mm. As you can see in the childhood photograph, there is no change in his face turn or his exotropia when comparing to his childhood photograph and the present photograph. So on examination, the patient had persistent face turn, as I told, and also the exotropia in the primary gaze is made out, along with the limitation of movement in the left eye of about -4 on adduction and -2 on abduction. So in this patient, we decided to explore the left eye lateral rectus muscle, following which the recessed bands of the lateral rectus was attached and later attached to the periosteum. So on force section test, the FTT was the LR was tight, and the limbal incision was made, following which the two bands of the lateral rectus muscle was identified and sutured together. And after the bands were tied together, the lateral rectus muscle bands were then fixed to the lateral periosteal wall with a non-absorbable suture. And to make sure it is fixed to the periosteum, and to prevent the reattachment of the lateral rectus bands to the globe, the tenons was put in between the globe and the lateral rectus, thereby preventing the reattachment and preventing the recurrence of exotropia. So this is the important step in the lateral rectus periosteal fixation surgeries. So following surgery, as you can see, the patient head posture is completely gone now, and the patient And though the extraocular movements improvement were there, it was very minimal. The adduction had improved to -3 and the abduction had improved to -1. But now the patient was able to use his binocular single vision, and it had helped him greatly. So now coming back to our initial case, who had also underwent the same procedure in his right eye. The patient did not have any face and post-surgery. The Hirschberg was central, and there was even improvement in the palpable fissure in the right eye. And finally, the patient was happy with the outcome. And since then, he has been stable for past 3 years. So this is a comparison of the clinical photograph before surgery and after surgery. As you can see, there is an improvement in the size of the palpable fissure, and also the head posture has been corrected. Thank you.
Thank you, Ragasudha. I think your case is very nicely showing that how there can be a seesaw because of multiple surgeries if they're not properly planned, especially in cases of Duane's retraction syndrome. You have to be very careful while recessing MRs that you don't over-recess, and otherwise you may convert an esotropic Duane's to iatrogenic synergistic divergence, or at least exo-DRS. So I think you have to be careful when you see these cases that you may require to do a simultaneous MR and LR recession in order to take care of that, and never overdo a recession. You may require minimal recession as per the FDT being tight. But I think what you have presented is very nice. I think let's have opinion of people, what they say.
I think just to add that since it was a resurgery, I think I would go in for an MRI. Important to see if we are able to pick up. Like in this case, we felt that there was some attachment. We are somebody who's very good in picking up. So I thought that I should go and explore, and always do an FDT on table before starting the case, intraoperative. So you really know whether it is fixed or not. The other thing is that the lateral rectus was actually on the inferior orbital margin. And in fact, when I was going in the space, I realized I couldn't find it, and then it was attached. So it's important that if you are planning a lateral orbital periosteal fixation, ensure that the lateral rectus is completely off from the globe, doesn't stick back in any way. So putting a tenons in between is very important so that the complication. So if you don't know the right technique, it can cause a lot of issues like this. And because of which the inferior oblique was also pulled downward. So there are multiple things. So the idea of this is to show the right technique. And I said what Dr. Ramesh is doing externally. This is what we try to do internally. Pass a non-absorbable suture through the periosteum, pull and see whether it is completely within the periosteum, and then put the muscles to it, ensure that it is way behind with the tenons well separated, so that we will not prevent the same thing getting reattached. Because then going back when it's behind the equator will be very difficult to then try to get and detach this muscle subsequently.
Yeah, I agree that we don't have to do an external incision most of the times. We can manage through the same tenons approach. We can see the periosteum and pass a suture there with a little bent needle. I mean, the same needle, you can actually curve it more so that they are little more, in smaller, narrow space, you can pass them. And I usually don't have to do a skin incision approach. So I agree, that would be there. Yeah,
Dr.
Dr.
Molnar, you do these. Do you have any suggestions for technique? One, and two, has anyone had to go back in on these later, and what does that look like? So, Andrea, any technique suggestions?
Yeah, well, I like the skin incision because I think I'm more convinced that the muscle, as Dr. Jyoti said, we have to make sure that this lateral rectus will never touch the sclera again. So as much further away as possible, to place it as much farther away as possible. And I feel that by making the skin incision on the orbital rim, I pull the muscle very, very far away from the globe. So this is why I like that technique.
Mm-hmm. No, but usually the attachment is happening in the orbit and more posterior. So your skin incision usually doesn't help. What you need to do is a compartmentalization by using this tenon sutures in between the lateral rectus and
I agree.
and the globe.
I do that too. After placing the muscle there, I also close the tenon in between. Yes, that's correct. But you remember that the muscle, and you can see that very often in traumatized and lacerated muscles, the muscle has a special type of tropism for the sclera, and it tends to look for the sclera again.
Correct.
So this is why you must make sure that the muscle is as far away as possible.
Yeah. Correct.
Dr. Clark, I'm wondering whether or not the pulleys have a role when we're moving this muscle to the periosteum. Do we have to worry about, have we shifted the pulley as well? And is there a role for that?
It's an interesting concept over here. To me, the interesting part about it, I've done one of these under a topical and local anesthesia on an older gentleman over here. And even after detaching the lateral rectus, having no attachment laterally, the eye is still exotropic. So what is rotating the eye in exotropia? I think it's actually the orbital layer attaching to the pulley and pulling that eye still exotropic. So he was still 5 prison was exotropic, even with the lateral rectus completely detached. And so I think you have to be careful about pulling the muscle too far anteriorly, because you may inadvertently actually strengthen the orbital component of the pulley. You should try to keep it in there. And have not done this yet. I thought about trying to actually suture the pulley to the lateral orbital wall to try to minimize its movement. In other words, how can this patient with no lateral rectus still have an exotropia? And the answer is there's still some forced transduction from the pulley system onto the globe temporally. And if you could remove that, then you may be able to augment your effect of less exotropia.
And has anyone had to go back in and reverse these procedures?
No, not yet.
Once we kill
Not
it, we
yet.
kill it, I guess.
No one wants to go back into it.
You're right.
I actually
I
had
think
a
it's very
case,
difficult to overcorrect these patients over here. So in terms of trying to like re-secure, you probably do more on the lateral side. Once again, is there still residual force more so than having the patient be a large ESO? I've not seen a large ESO after these procedures, which you'd expect one because you actually move the lateral rectus.
I've had a case of traumatic third nerve where I did that procedure with an open technique with my orbital colleague. And then I thought that there was still attachment because the patient was able to abduct the eye still, and the eye was still exotropic. So I went back, I looked for any connections or attachment of the lateral rectus to the globe. I couldn't find any. So I think that proves the pulley theory of that the pulleys are actually the ones that are responsible for abducting this eye, despite the successful fixation to the periosteum.
Yeah, I cannot claim primacy on that. There's actually a group in Italy that showed that you detach the lateral rectus, the eye just moves around just fine, which is very shocking, but it's true.
Jan Polsky showed that once, I remember.
Right. So you think, okay, what would be the next step?
And Alan Scott did that.
The next step would be to
Yeah,
go
Alan
ahead
Scott
and
did
take
that
care
as
of
well
the
under
orbital
local
part of the
anesthetic.
pulley.
I think let's have the next case because we are running out of time.
So the last case is from Singapore. Dr. Katerina, please.
Dr. Katharina, you're muted. You're muted.
Katerina.
Oh, I'm so sorry. Yes. Good evening, everyone. Good evening from Singapore. Thank you for this opportunity to present my patient, who is a lady who was first diagnosed in 2017 at the age of 35 years old with right cerebellar vermis tumor, histologically proven to be pilocystic astrocytoma, for which she underwent resections of the tumor twice in 2017 and 2020, and also completed chemo and radiotherapy after her second resection. In August 2020, she was referred to a neuro-ophthalmologist in another center for complaint of binocular vertical and torsional diplopia right after her second surgery, and she was diagnosed with right fourth nerve palsy, fitted with Fresnel prism, which relieved the vertical diplopia as expected, but not the torsional component. And then in 2021, she was referred to our center. Unfortunately, serial MRI brain between 2021 to 2023 showed a slow progressing lesion, which required chemotherapy yearly between this period. In 2024, however, finally, the MRI brain showed stable lesion, and she was eventually referred to Strabismus service for consideration of surgery. This is just her images from the MRI showing the large posterior fossa tumor preoperatively in 2017, and her latest MRI, which showed post-surgical lesion in the posterior fossa now filled with CSF, but otherwise no other new lesion. So this is the eye examination finding when she was first reviewed at our center. So of note on primary gaze, she has a esotropia that seems to be worse on down gaze, also has a small right hypertropia that is otherwise quite similar on right and left gaze, slightly worse on right tilt. On left tilt, however, there seems to be a reversal of small left hypertropia instead. Double Maddox rod showed a bilateral X cyclotorsion, and this is her ocular motility photos. Of note, she does appear to have a bit of underaction of the right superior oblique. The left motility appeared full. This is just to show you the trend in December 2021. Again, similar picture of right ESO as well as right hypertropia. That is worse on left gaze and right tilt with double Maddox rod showing 20 degree of X cyclotorsion of the right eye. Similarly, in September as well, which fit the pattern of right fourth nerve palsy, torsion was otherwise stable. And in 2024, this is her examination finding when she was reviewed by our strabismus team. Similar picture of right hypertropia, worse on left gaze and right tilt, with double Maddox rod showing X cyclotorsion of 20 degree in the right eye. However, on ocular motility test, it seems like bilaterally the superior oblique were underacting, and fundus photo showed bilateral X cyclotorsion. At this point in time, we were entertaining the possibility of bilateral fourth nerve palsy instead. We reviewed her one more time in December and with similar findings. The torsion was otherwise pretty stable. So the discussion would be possibility of this patient having bilateral fourth nerve palsy. And I would like to hear from the panels your opinion about the surgical approach for this patient. Would you just do one surgery in the right eye stage procedure, or would you do both eyes at the same time? And then surgical approach, of course, many would consider doing Harada Ito for the large torsion. Would you do adjustable? Will anyone consider doing IO weakening procedure with anterior nasal transposition? Thank you very much.
I think, Catherine, in this, it's very clear that it is a bilateral supraoblique palsy. The features being that there is a esotropia, V-ESO, almost ortho in the up gaze. She may be having a chin down position, most likely. She has a torsion of 20 degrees, which is way beyond what we expect in a monocular supraoblique palsies. So it's definitely a bilateral supraoblique palsy. And as far as the technique from my side, I would like to do a bilateral Harada Ito procedure, because here the primary problem is torsion, and that would be best corrected by that. And that would be my technique. Maybe one adjustable Harada Ito on one side, and other side you can have a regular Harada Ito.
I would agree with so much of exactly torsion around, and if the double Maddox rod showing you around 20 degrees, I think you should go in for a bilateral Harada Ito. Means the Fels modification, I think that will be much better. And but there could be another approach also if it is, I don't know if, because if you don't want to touch the superior oblique, then even you can do a nasal transposition of the IR along with an inferior oblique, recession. I don't know if that might also help for the bilateral exactly torsion.
If you do a nasal transposition of the IR, are you worried about worsening the esotropia and down gaze?
Yeah.
Yes.
So
Yeah.
I think,
Yeah.
and that may not correct that much of torsion also.
That
So I
much.
would think that supraobliques would be a better thing to do.
But would you do a stage approach or go for both eyes simultaneously? That's the question.
Yeah, I would do on the same time one adjustable. On one side, I will keep it on an adjustable. And as the Dr. Suma mentioned, it's a Fels approach, a modified Fels approach that we do. That means we have an advancement of the anterior fibers on the adjustable suture.
Pradeep, in your hands with a paretic superior oblique from a fourth nerve palsy, how much improvement in the X-cyclotorsion would you expect to get with a Harada Ito?
We do get a lot of good corrections in these. I mean, for every millimeter of advancement, it's usually a 1 degree you can correct. And so if you're doing a bilateral, you may be able to correct this 20 degrees of extortion.
I just wanted to add, like, actually, we can look at the MRI. Go back into the MRI to look at the superior oblique, the hypoplastic part. Is it one or both? That could give us some clues, whether it's one eye or both eyes. And there has been reports that actually in some cases of unilateral superior oblique palsy, they can also have huge extorsion. It's much rarer, but so to be very sure, we can actually look again at the MRI or ask our radiologist to look at it.
Yeah, I'm wondering if these images of the retina, when you're taking pictures, how much you can rely on that, because the patient may change fixation while they're having a bright light in one eye versus the other eye. Does it change what you actually see, and can you rely on that as a component of deciding that this is bilateral?
Actually, I
I
think
agree
that,
with you. Go ahead, Jair.
yeah, sorry. I think that these pictures, I rely on them. I think that measuring the distance between the macula, the fovea, and the center of the disc is the horizontal deviation. It's really, it gives us a lot of information about the excilotorsion, and I think it's a good measurement. Do you think differently, Andrea?
No, I agree with David in the sense that you can have patients with unilateral superior oblique palsy where you see the extorted eye, even an extorsion even bigger on the contralateral eye, on the sound eye. So I don't rely on this information much. I rely on the total amount of excyclotorsion.
Exactly.
This I like to see, but this doesn't tell me if both eyes are affected or only one.
But Andrea, in this, there is a underaction of supraoblique on either side.
Yeah.
And the
That's
other thing is
correct.
that
No.
The reversal of the hyper.
I totally agree. I don't say that this patient does not have a bilateral. I say that I don't rely on an image, a fundus image that is bilaterally extorted. But I agree. This patient seems to have a bilateral affection.
And second thing which goes in favor is less of vertical deviation compared to the torsion. So whenever you have a bilateral, you get a neutralization by the other eye, supraoblique, so that the vertical deviation isn't much, like in this case, whereas the torsion adds up.
Pradeep, when you do the measurements of torsion, are you using a Maddox rod? Do you use an amblyoscope? Do you do both to try and identify
use
the
a
amount?
Maddox rod. Maddox rod for subjective torsion measurement, yes. And if the fundus pictures also, I do take measurements. That also helps. We have compared. That is what we do. Yeah.
It's a fundus camera, the Canon, and I don't have financial interest, Canon RX. It has a retractor as a program, as an app inside the camera that measures you very precisely how much torsion you do have. I use it very much.
Wonderful. Thank you.
Yeah.
So one question, anybody uses a Holmes dots to check for the torsion on table?
I don't use it. But it's quite a neat technique where he marks the and uses the Jonathan Holmes technique when he sees the torsion. I usually just look at the fundus using the Guyton technique.
That's right.
Another fabulous case in discussion. So, Wade, do you want to wrap up?
Yep. Okay. So to wrap up, I would want to thank everybody for participating in today's conference, and I would again want to ask everybody to please join us in WSPOS. There are lots of advantages to joining us. Membership is free, and we look forward to having you at the next conference. And shout out to David Granite. Lisa, please join Lisa.
So, Thank you all the speakers and the panelists, especially Dr. Andrea, Clark, Dr. Hunter, Dr. Shatha, and the panelists Jyoti, Yair, Suma, and Shove. It was a wonderful presentation, and of course the case presentation by Grishma, Lubhavani, Ragasundha, and the last one, which was all wonderful. I think it's a lot of learning today. Thank you all.
Thank you.
And
Thank you,
Thanks very
everyone.
much.
before we
We
say
need
bye,
more
let's take a
time.
photo.
Okay.
Let's do a
Have a
quick
great-
photo.
Have a great rest of the day around the world.
Right. And
Thank
thank you
you. Same to
everyone
you.
for the wonderful and productive sessions. And this brings us to the end of the first day of International Ophthalmic Conclave. And we will meet you all tomorrow at 10 a.m. per IST for some more interesting sessions. And we will be starting the symposium on infectious keratitis in Hall A and biologicals and uveitis in Hall B. And I think Dr. Aditya, thank you so much for being there and coordinating the session amazingly. And I think he needs a photograph for all of you. So
Yeah.
please.
So
Yeah.
raise
Thank you,
that thumb.
Ralika.
Excellent.
Okay.
Good night.
Have a good day and have a
Have a
good
good
night.
day.
Good night and good night.
Bye.
Yeah,
Good
bye-bye.
Day.
Thank
Bye.
you all again.
Thank you, David. Yeah, bye-bye.
Thank you,
Bye.
Pradeep.
Bye. Bye.